Uh, Mr. President, ladies and gentlemen, thank you very much for asking me to talk today. My name is GED Howell, I'm a consultant orthopaedic surgeon. I'm based in South London, working at the Elective Orthopaedic Centre, doing hip and knee, lower limb arthroplasty. But I've also got a weekly commitment to trauma at Croydon University Hospital. Right, what we're going to talk about in safety and trauma is pre-trauma, immediate management and definitive care. Pre-trauma is up to you to avoid it, so don't fall off tall buildings, don't play dangerous sports, don't show off with fireworks, get run over, drive a car whilst blindfolded, jump out of a plane or lay down on railway tracks. Those are the don'ts. The do's are stay indoors, use only soft furnishings, ensure all walls are padded, wear a crash hat, use a safety belt at all times, and preferably live in a bungalow. That's pre-trauma covered and safety. The immediate management is obviously first aid, and that's very variable throughout the world, and also within any individual country, very variable within the city where you're injured. I would like to talk about the immediate management, and that's when you actually get into the hospital, and obviously the advanced trauma life support doctrine is the way forward. It's very didactic, and you cope with all aspects of trauma. I'm sure everybody is aware of A, B, C, D and E. Airway, within life cycle immobilisation, breathing, circulation. I like to call D, deformity, is disability, and E, extremities. If you're didactic and you follow these rules, you will treat each and individual patient safely. You need to be seen if you have trauma in a dedicated trauma centre. The dedicated trauma centre is designated as grade A1 and should have an ITU, departments of general surgery, orthopaedics, vascular surgery, cardiothoracic surgery, neurosurgery, and access to interventional radiology, including MRI and CT. You must have in that hospital a dedicated trauma team, the first and most important of which is a team leader who acts as a coordinator and recorder of events. Within that team, seeing each and individual patient that arises within the department, there should be a consultant anaesthetist, a consultant orthopaedic surgeon, a consultant general surgeon, and a consultant radiologist or senior radiographer. There should also be a series of trauma nurses. Everyone should be kitted up appropriately, including preventive clothing and also radiological protection. The definitive management uses the qualified and trained team, and usually following initial assessment through the advanced trauma life support system, a plan of treatment is performed. And this is essentially non-surgical, surgical, or a visit to the mortuary by the patient. Planned surgery. This is the key to safe management of all patients. The whole team involved in the management of the patient should get together pre-surgery to actually talk about what is going to happen to that patient. This is particularly important if it's a multidisciplinary approach to the individual patient with trauma. All procedures should only have one E in them, as I've just noticed, rather than two as on the slide. All procedures should be discussed between all members of the team that are actually involved in the care and management of that patient. This includes not only the surgeons that are going to be doing the surgical practice, but also the assistants, the anaesthetists, the nurses, the scrub teams, and also ODAs and ODPs within the theatre. The order, once the management plan has been provided, should then be written down and placed on the wall within the theatre. This should ideally be next to the radiographic boxes, and ensure that all staff within theatre know what is planned for the individual patient. I'd also go so far as to say that those people that are involved in portering should also know exactly what's going on in terms of management of the patient, because these are the guys that are critical when you actually need certain instruments, certain prostheses, bloods, or actually returning blood to the patient from the laboratory. There is no point in having the best team in the world with the bleeding patient, but nobody to actually go down to the laboratory to get the blood. I cannot stress more importantly the following four words: who, safety, check, list. And this will be covered by the President in the next talk. Reiterate who, safety, check, list. It's essentially everything stops pre-surgery, a series of checks including the name of the patient, the identification of the patient, including the identification number on any bloods that are going to be given to the patient. The consent should be reviewed concerning the signature of the patient or the patient's guardian or and the surgeon that's actually taken the consent. Body warmers applied, antibiotics given, DVT prophylaxis. The operation, as I said, should be planned. Everybody should know what's going to happen and in what order it is going to occur. All requirements for the surgical procedure should be known by all staff at all times. There should be no surprises. Having said that, we've all been in a situation where suddenly something happens that you haven't planned for, but if you have a dedicated, competent team, then there should be no reason that any eventuality should not be covered. Any special requirements that are needed should be recorded and made available so that everybody knows, again, everybody knows what is going to happen to the patient. Any special instruments that are required are actually obtained before the patient is actually undergoing surgery. Any special prostheses that might be used in terms of orthopaedic trauma are available in theatre. On top of all of this, it should all be mentioned that we all want the surgery to go swimmingly well, but we should discuss potential complications. And those complications can range from untoward bleeding, suddenly identifying a fracture that's much worse than you'd initially thought, suddenly identifying trauma that wasn't expected, whether that happens to be intra-abdominal or intrathoracic or intracranial. And what we should also look at is the timings. You should anticipate the timing of each individual surgical procedure that's going to be performed on the patient, and also, therefore, you can inform the anaesthetist what sort of anaesthesia to be given and how long he or she would anticipate to be giving anaesthesia. The conclusions from this short talk should be: don't be the subject of trauma yourself. If you are, then you need to attend a dedicated trauma centre with dedicated staff. All of these patients that are seen in the trauma centre should be ATLS'd. They should all go through the ABCDE. Planned management should then ensue, and that is a multidisciplinary approach, including those from the ITU, general surgical departments, cardiothoracic, neurosurgery, orthopaedics, and planned treatment described before proceeding to definitive treatment. When definitive treatment is due to commence, the WHO checklist will be followed. Further conclusions: be didactic. If you are didactic, you will not miss anything and the patient will be treated successfully and safely. Be safe at all times. That's not only with respect to the patient, but also with respect to yourself and your colleagues and all those in theatre. Most importantly, if you're didactic and you're safe, you will stay alive if you suffer trauma. Thank you.